All right, guys, I am going to be doing your last review for your exam. So, little change in plans on how I'm going to do this. So, you guys you did so much content for this to be like a video plus a whole exam review. So, you guys did chronic neuro, you did like peripheral nerve, you did shock SIRS and mods. There's just a lot of content and I don't want to create a super long video. So I think what I'm going to do is film this and then I'm probably just going to post something, either a quick video or just like a document about each topic and just some things that I went over in the previous review videos that I think you should know. I feel like since I've been doing videos every week and going pretty in depth with each topic, that you guys don't really need a general review video, if that makes sense, because I don't really have anything to add. It's all been said in those individual videos, if that makes sense. So, as always, if you have any questions, feel free to reach out to me. I've had quite a few of you guys reach out to me already, and that's great. So, okay, so I'm gonna do chronic neuro first, which is mainly headaches, and Parkinson's. So, this stuff, if I remember correctly, is not as big on the exam. I feel like I've said this multiple times, but your exam is primarily stroke, ICP, and then maybe stroke, ICP, shock, and then questions here and there from all these other topics. So I feel like if you understand stroke, shock, and ICP, that's really the bulk of the exam. Obviously you need to know this other stuff too, but there's not going to be as many questions, if that makes sense. So starting off with headaches, I first have sorry. Starting off with headaches. So headaches are one of the most common pains experienced in humans. I mean, I'm sure we've all had a headache before, and it's a big nursing diagnosis with acute pain. And so pain management is your main focus with headaches. You got to educate on triggers, treatment options, but for the most part, pain management is the huge thing that you're going to be focusing on, and how to control the pain, how to cope with it, and how that affects quality of life. There's medications that we're going to talk about, things like that. So tension headaches, going into the specific kinds. So tension headache is often caused by stress, and it's the most common kind of headache, and it's just a constant dull pressure, and it can last anywhere from 30 minutes to 7 days, and you could have this for years and years on end, just kind of in cycles. And it's a tightening or squeezing, almost like a band around your head, and it's usually bilateral. So that is probably what you need to know for tension headache. As for what it is, usually you're not going to have nausea, vomiting. You might have a stiff neck, might have some sensitivity to light and sound, but you're really just going to have that tension, that band of pain. Diagnosis really for most of these headaches is going to be just looking at your assessment, ruling out other conditions, looking at your health history, things like that. Treatments, same thing. It's gonna kind of bless me, sorry, it's gonna overlap. So yeah, okay, so migraine headaches, these are probably the most common one that we think of when we think of headaches, because I'm sure a lot of people have had these before. One thing I think that's worth noting is that migraines are more likely to have specific triggers. So hormones, certain additives in food, that sort of thing, stress. So I get migraines and mine are hormonal, and so I know that's my trigger. As far as clinical manifestations, I mean, once again, that can change depending on the person. So for me, my migraines have aura. So I get little rainbow, almost like you're looking in a kaleidoscope. I get that in my vision and I essentially go blind. Really freaky the first time it happens. I thought I was having a stroke, but literally, like, that's my main symptom. I do get pain with them sometimes, but it's not every single kind or every single time that I get pain. So it really just depends on the person, but usually the pain is going to be throbbing with a pulse. It can be disabling, lasts up to 72 hours. And unlike tension headaches, these are usually unilateral, but it might switch sides. So, like, for me, I know mine are usually on my right side. I'm not really sure why. You might also have that nausea, vomiting, sensitivity to light and sound, that sort of thing. Once again, look at labs, look at your assessment, and really CT and MRI, we don't order that for headaches unless you have like an abnormal neuro assessment. Talking more about migraines with medications. So with headaches in general, you can use non-opioid analgesics, so like your aspirin, your Tylenol, ibuprofen, that sort of thing. One thing that's worth mentioning is that, remember, if you overuse NSAIDs, you can get GI upset, and Tylenol can cause liver failure if you have like frequent use. And the way I remember that is Tylenol, the L in Tylenol, and then there's an L in liver. So good thing to remember. And then like ibuprofen can affect your kidneys. So that's something to keep in mind. There's also triptans. So that's what I use for my migraines. I use sumatriptan. The one important thing to keep in mind, and this will definitely be a question I have a feeling on your exam, is you don't give any sort of triptan if they have a history of heart problems. So that's like an immediate contraindication, because the way that triptans work is they constrict the arteries. So if you have a history of heart problems, that can obviously be fatal or like really serious. So usually those are used for pain as well. You can also use corticosteroids, sedatives, muscle relaxants, that sort of thing. But I think the biggest thing with medications for headaches overall is going to be the triptans, and then also remembering that NSAIDs over time can cause damage to your GI tract, and then liver failure for acetaminophen overuse. And I don't think this would be a question, but if you were to overdose on Tylenol or acetaminophen, you would use acetylcysteine. That's the reversal. So good information to have. So that all of those medications that I just talked about, those are all for symptomatic treatment of headaches, migraines, tension headaches, whatever. So you're going to use those when you have pain. There's also prophylactic medications that you can use. So Topamax is the one that I have highlighted. That's used most of the time, but stopping it suddenly can cause seizures. So that's really important to keep in mind. Also, I know these medications can interact with like birth control. They can interact with like antidepressants. So it's a little bit harder to get patients on these medications. And that's why headache treatment is most often symptomatic treatment rather than prophylaxis. But that is that. And then cluster headaches, these are going to be the headaches that are like severe, sharp, stabbing pain that happens like multiple times a day, and it can last up to hours. These can cause tearing, swelling around the eye, restlessness. Usually the pain is like all over, so like your eye, temple, forehead, that sort of thing. And the biggest thing with these is that they greatly impact like quality of life. And I remember that Dr. Schneider talking about in class how like these headaches, there's a really high prevalence of suicide in patients that have cluster headaches because the pain is just so unbearable and they can't control it that they like take their own lives so they don't have to deal with it. It's not as common, but obviously it's still debilitating to those who have it. Symptomatic treatment, I know this was a question on our exam as well. One thing you can do for treatment is oxygen delivery, which I think is kind of cool. So you can do 6 to 8 liters for 10 minutes. with a non-rebreather mask or a Venturi mask, and then you do 5-minute rest period. And so this is really good for like a short-term like solution. So if a patient comes into the ER and they're having a cluster headache, then you can like give this treatment and it should help them, but it's like not going to cause it to go away, if that makes sense, for long term. And then those medications that we already have talked about can also be used for this. So that's all I have on headaches. So like I said, the big things, I would just know like what a tension headache is. So that's the one across your head. Know a migraine, that's usually with the nausea, sensitivity to light, unilateral. And then your cluster headaches are like your severe, like just really debilitating headaches, the ones that cause tearing, can lead to suicide, and that's the one with the oxygen delivery for treatment. And then as far as your meds go, I would know about Topamax and how you can use that for prophylactic reasons, except you shouldn't stop it abruptly due to seizures. And then also know about your triptans and how you shouldn't give those unless you are sure the person doesn't have any cardiac history. So that is that. I don't remember there being more than maybe like 2 or 3 questions on the exam about headaches. So, like, I feel like if you understand what I just said, you'll be fine. I don't know. I have so many tabs open. What is the next thing that you guys talk about? So you go from headaches to multiple sclerosis. I don't think, hold on. Okay, I'm gonna go to seizures next because that's how my notes go. I don't even remember seeing seizures in your guys' PowerPoint, so hopefully. Anyway, okay, so seizures, I remember I was very like, I don't want to say, I think I was more overwhelmed when looking at seizure content because there's just a ton to know about seizures, but I feel like if you understand the basics, you'll be fine for the exam. There's not more than maybe 2 or 3 questions on it from what I remember. So a seizure is uncontrollable firing of neurons, and usually it just kind of comes in waves. And they're usually idiopathic, so they occur without a cause, which is kind of scary. Fever is the number 1 cause for seizure in like infants and kids under 2. And then usually like over 2, it's from trauma, infection, or just genetics. There's lots of different kinds of seizures. So there's 2 classes of seizures. You have your generalized and you have your partial. So your generalized seizures, they involve both sides of the brain, whereas your partial, they involve one side of the brain. So your generalized seizures, those are going to be like your grand mal seizure, which is also known as I never say this right, tonic-clonic seizure. They usually have no warning. You're going to have stiffening, which the stiffening, that is the tonic. That means stiffening, like increased muscle tone. And then the jerking is the clonic. So if you remember that, I feel like you can like differentiate these types of seizures. Just remember that like tonic is like the jerking, increased muscle tone, that's the stiffening, and then the jerking is the clonic. That's the like moving around. Usually they're not going to remember it after. Absent seizures, so these are usually in kids. I had a kiddo at my preceptorship who actually has absent seizures, and like the best way I can describe it is it's literally just like they stare off into space and then like they won't remember anything from it usually. That's what I would keep in mind about absent seizures. Myoclonic, these are when you jerk and usually like fall to the ground. This is why like kids that have myoclonic seizures usually wear helmets. Usually wear helmets because of that. Atonic is the drop attack, so that's when you just like lose your tone and you fall to the ground. Kids that have that also usually wear helmets. Tonic, remember we talked about tonic is like the stiffening, so that's essentially what that is just a seizure where you like stiffen up increase that muscle tone. And then clonic is like the flailing, so that's that type of seizure. And the big issue with clonic that I have highlighted is respiratory status. I feel like you worry about respiratory status with all seizures, but I think that one, that's like the biggest thing. And you also worry about falls. So partial, like I said, those are seizures on one side of the brain. So you have simple and complex. So simple, usually you lose consciousness for like a minute maybe. Complex can involve other behavioral changes, but it's usually like localized to one part of the body, and it usually comes before another seizure. I wouldn't stress too much about the different kinds of seizures. I don't really remember there being questions on that. And like I said, I remember I used to get confused by that. I would know your phases though. So your prodromal is before your seizure. Your aura is like the sensory warning. So like with headaches, we talked about how you can have that aura, like how I have the vision changes, and that tells me that I'm going to be getting a migraine. Same thing. You can have something that happens before your seizure that tells you that that's going to happen. Ictal is during the seizure, so like your primary concerns are respiratory, loss of bladder and bowel, and then just overall safety. And then post-ictal is after the seizure, so that's when like patients might have forgetfulness, want to sleep, be confused, that sort of thing. Complications from seizures, status epileptic, I can't say anything. Status epilepticus, that's the like continuous seizure activity that happens like greater than 5 minutes. And so you're really concerned in this case about like a cardiac dysrhythmia, hyperthermia, that sort of thing. And these are treated with benzodiazepams. And so remember, that's anything that ends in a PAM. So like lorazepam, for instance. But you don't give them anything orally. Diagnostic wise with seizures, you want to show or you want to look for abnormalities. So EEG, CT, MRI, labs, because you're trying to rule out other things. But you have to classify the seizure in order to treat it, because each seizure is treated differently. And so, like, obviously that's important to know. So medications, seizure medication should never be stopped abruptly. Remember that. And you have to remember that like each type of seizure is going to have a different kind of medication. So if we're looking at like, for instance, like absent seizures, so like Depakote, that's one that I remember hearing a lot about in class, that you can use for absent seizures, whereas like tonic-clonic, which is the one where you're just like doing everything. Dilantin, I remember that one. Tegretol, Depakote, and phenobarbital. I would remember those 4 and just be able to establish those with seizures, or connect those with seizures. One thing I have highlighted for Dilantin is you have to monitor liver labs when you have a patient on Dilantin. So remember that. Dilantin, liver. Once again, Topamax comes up again, which we already talked about. That sort of thing. I do remember there being a med question about seizures. I think it was about Dilantin. So I would just be able to recognize like Dilantin, Tegretol, phenobarbital, Depakote, like those are all seizure meds. Collaborative care for seizures, you can have surgery to remove like the focus and to reduce your seizures, but it also depends on the type. You can do vagal nerve stimulation, which is an implanted electrode that creates impulses to reduce activity. And I also had a kiddo at my preceptorship. My preceptorship is on the pulmonary floor, but we've actually had a lot with seizures. So I had a kiddo who had one of these, and she had to go get it replaced because the battery was like low. And so obviously that's not going to do her any good if she has a seizure. And then also sometimes you can have people on a keto diet, so high fat, low carb, because then it replaces the glucose. So it helps your body or your brain not to be so like active. Really, the biggest thing that I would say with seizures is just like your precautions, which I feel like you guys should know by now because they've probably been drilled into your head. But just remember, you should always have oral airway, suction, oxygen at the bedside. You should always have a working IV in case you need to give meds for like if they have status epilepticus, for instance, because you can't give anything PO. Padded side rails. If you have a patient that starts to seize, the first thing you do is you're going to turn them on their side. Always, always, always stay with the patient and call for help. You never leave them. You're going to want to time your seizures, so somebody needs to be in charge of just like keeping track. Guide them to the floor if they're sitting or standing. Clear anything around them that they might hit. You don't want to like restrict them. You don't want to like stick anything in their mouth. Never, ever, ever place something in their mouth. If you know that they're gonna seize, you can put a bite block in their mouth so that they don't bite their tongue. But like if they're in the process of seizing, you're not gonna put that in. And one thing that I have highlighted that I feel like I remember being on the exam somewhere, maybe not, I don't know, was that if you have an unwitnessed seizure, so if you walk in and you find a patient and they're like, oh, I just had a seizure, you're going to treat this as a spinal cord injury. So you're going to immediately put them on C-spine precautions and place a collar because you don't know what happened. So who knows? They might have just had a C-spine injury. And then after the seizure is done, you're going to want to just like be prepared to suction, help reorient them, get vitals, do a quick head to toe, that sort of thing. Yeah, so I have another note on Delanton. So I feel like our question was on Delanton, but that's the one that you're going to draw labs on because you're looking at the liver. And yeah, don't stop any seizure medications abruptly. That is all I have on seizures. So I know you guys aren't doing restless leg syndrome, so I can skip that. Okay, the next thing I have is multiple sclerosis, which is very common. So this is a chronic progressive degenerative disease of disseminated demyelination of the nerve fibers in your brain and spinal cord. Essentially what that means is that the nerves are just like breaking down. This happens more in women and it usually has a younger onset between 20 and 50. It's not really known why this happens, but genetics or drugs are thought to play a large role. Usually you're going to have a gradual onset in your patients that have MS, and it's going to be more like vague symptoms in the beginning. So I have this highlighted, and I know for a fact this was a question about how the earliest signs that you're going to have with patients who have MS is disturbances with bladder and bowel function. So like they might all of a sudden have incontinence, or they might have retention or constipation, things like that. Like that is going to be the number one sign that somebody is potentially going down the path of MS. Over time, they're going to develop more weakness, paralysis of the limbs. They're going to have impaired speech, LOC changes, Lermitz sign, LHERMITTES. That's like a shock that's sent down the legs when your neck is flexed with MS patients. That sort of thing. So that's like all your signs and symptoms. Diagnosis, MRIs can show like the atrophy, the plaques, the tangles. I would remember that plaques and tangles are associated with MS, and then you can also look at their cerebral spinal fluid. As far as medications, it's mainly going to be symptomatic treatment because that's just like what you have to focus on. So that could be like muscle relaxants. You can also use corticosteroids, but you want to remember with corticosteroids, you don't just stop them, monitor your blood glucose levels. And then you can also do disease modifying drugs. But like, that's about it. Management is really just going to be about, like support groups, supporting these patients, letting them talk out their feelings when they need to. They're going to start losing independence and they're going to start having more issues. So I think that's probably the biggest thing I would remember with MS patients is like it's pretty debilitating. And so you want to be supportive of them. If they start having bowel and bladder function issues, you might have to straight cath them Q6. You want to minimize, like, or no, never mind. I'm not going to say that. You want to maximize their independent function, front load their ADLs, which means you want to manage their fatigue. So have them do the things that are more important in the morning so that they don't get like fatigued throughout the day and then don't have enough energy to do their ADLs in the evening. And just like promote as much independence and whatnot as you can. But yeah, so they might have to be straight cathed. And yeah. That is all I have on multiple sclerosis. And then the next thing, and going back to the bowel and bladder, so like I said, they might have constipation, so that would be like teaching your patients to like maintain activity levels if they can, and then also to increase fiber, and like minimize caffeine so that they can maintain good habits. And then they should also work to identify triggers that might cause them to have more pain or more weakness. So next I have Parkinson's, but I think I'm actually going to jump into, since multiple sclerosis is a peripheral nerve disorder, I'm going to jump into the other ones. So trigeminal neuralgia, Bell's palsy, and then Guillain-Barré syndrome. Okay, so trigeminal neuralgia. So this is brief, sudden stabbing pain of the trigeminal nerve, which, if you remember, trigeminal nerve is cranial nerve number 5. It also has 3 branches, so you don't need to know that, but it affects like a good portion of your face. It's also called tic douloureux. Also not really well understood, but the biggest thing about this is it's very, very debilitating. So I remember this comparable to like the cluster headaches and how like patients with this have a high risk for suicide. This one more than cluster headaches, because it's so unbearable and so painful. They're gonna have pain down like their lips, their cheeks, their jaw, forehead. It can last for like 2 to 3 minutes at a time, but it's usually abrupt and lightning like. So it's almost like a shock across like half your face. You can have tearing of the eye, yawning can cause it, temperature changes, just like brushing your teeth can cause it, and it's usually unilateral. Your diagnostics, you're gonna just do your H&P, neuro exam, CT and MRI to rule out other things. So anti-seizure medications are used pretty frequently with this, just to like decrease the excitability of the nerves. So remember your seizure meds. The biggest thing with this, like I said, is that patients are definitely at an increased risk for suicide. So your psychiatric evaluation is really important. You want to educate on triggers and events that cause pain, how to control that pain. You also want to help make sure that your patients with this condition are not neglecting their hygiene. So like patients might not brush their teeth, for instance, because it causes them too much pain. There's also some surgeries that you can get. So like, I'm not even going to say any of these because I really don't even remember them. But you can get surgery for it too. But just remember the priorities with trigeminal neuralgia are hygiene, because of how they can neglect it, and nutrition, because your patients might not eat, it hurts so bad, pain management, and then the psychiatric evaluation. So that is all I have on that. So Bell's palsy is, I'm sure you guys remember from health assessment, there was like this big picture in the book about Bell's palsy. It looks like a stroke. It's essentially partial facial paralysis, and it usually results from inflammation, edema, that sort of thing, but it causes pain and alteration in that side of the face. Once again, not really sure why it happens, but infection, especially like herpes, is thought to like play a role, like viral infections. And this one deals with inflammation of cranial nerve 7, which is your facial nerve. So remember, trigeminal neuralgia affects your trigeminal nerve, which is cranial nerve 5. And then Bell's palsy affects cranial nerve 7, which is your facial nerve. I would remember that. So clinical manifestations, like I said, it looks like a stroke. So you're going to have facial droop, loss of taste, fever, ringing in your ear, pain around your ear. They might not be able to smile, wrinkle their forehead, or frown. There's not really a definitive test, once again, so you kind of just have to rule out everything else. Your nursing interventions, so you can apply moist heat, you can do a massage, your steroids, so like prednisone, for instance, you can take to help with the inflammation. But remember, as I've said with your corticosteroids, any sort of steroid, you watch your blood glucose levels, super important. And then also, you never abruptly stop steroids, you have to taper them. Acyclovir is also a drug of choice that you can use for this because it relates to HSV and like treating that. You can also use electrical stimulation of the nerve. But I have this highlighted, very, very important. Most cases are benign, and usually you can recover within 3 to 6 months. So it's really important to educate your patients that have this, that like your face isn't going to necessarily be that way forever. Like, I'm sure that there have been cases where it lasts long, but like overall, it's just important to remind them like, hey, you're not going to be this way forever. So nursing priorities, disturbed body image, because obviously half their face is not working. What's the word? Like drooping. So that can cause disturbed body image. They also can get dry eye and then also pain. And like I said, you want to treat with warm products rather than cold products. And then the last one that I have for peripheral nerve is Guillain-Barré syndrome. So this is acute, rapid, progressive, potentially fatal inflammation of many nerves. So you're going to have involvement of your cranial nerves, but you're also going to have involvement of your peripheral nerves. So it's polyneuritis because it affects so many different kinds of nerves. And really, this is another one of those, like, they don't really know what causes it. They also really don't know, like, what happens, but basically your immune system is targeting your nerves, and so your immune system is, like, attacking and just, like, demyelinating the nerves, so that's going to cause edema, and nerve impulses are going to be stopped. Like I said, we don't really know what causes this, so, like, immunizations. I know there's been a couple cases of this reported with COVID vaccines, but I believe there were also cases of this reported with the flu vaccines. I could be wrong about that, but I'm pretty sure like any viral immunization, you have a risk of this. And then like any infection, trauma, surgery. And one thing that's kind of confusing about Guillain-Barré for patients is it looks like MS in the beginning, but like it's obviously not MS. It's essentially the same principle because it's the demyelination, but the biggest thing that I remember with this, and I remember we had a question on this, is that you will recover with Guillain-Barré. It is potentially fatal, but like you're gonna start getting feeling back proximal to distal. So when you get your feeling back and you start getting function back of all these places that it's affected, it's going to go from top down, because if you remember, distal is like away from you, so proximal to distal. However, it's an ascending illness. So when you have your signs and symptoms, they're going to start at your feet and work their way up. So then when you get your feeling back, it'll go the opposite direction, if that makes sense. And so that's why the biggest thing that we worry about with Guillain-Barré is respiratory distress, because as the disease ascends, it's going to gradually reach the diaphragm and it can cause you to have respiratory problems. And so that's why it could be fatal if it reaches that, and you're more susceptible to like pneumonia and things like that. However, most people do recover from this, just like Bell's palsy. You will more than likely recover. And I remember we had a question. I can't remember if it was with Guillain-Barré or if it was with Bell's palsy. That's why I'm saying that this is important for both of them. Is that like, it was a therapeutic communication question, and it was like, what would you tell your patient with Guillain-Barré? I'm pretty sure it was Guillain-Barré. It was like, what would you tell your patient with Guillain-Barré? And the answer was that like you will gradually regain feeling proximally to distally, but there were answers that were like it's permanent, or like you will never regain function, that threw people off. So I would just remember that like it is possible to regain function from Guillain-Barré. It's not necessarily permanent. So those clinical manifestations: weakness, tingling, like I said, it's just whatever area it affects, the signs and symptoms are going to be related to that. So if it reaches your respiratory muscles, you're obviously going to have breathing problems. You're more prone to infection. If it reaches your bladder and like your bowel, you might have issues there, like incontinence. You might have sweating due to the autonomic dysfunctions, or like flushing, that sort of thing. Pain and muscle cramps, and then possible paralysis. Usually an MRI is going to be conducted to rule out MS. You might have to have a ventilator if you need that respiratory support, obviously. Steroids aren't really going to do much in this case, so going back to Bell's palsy, we usually will encourage steroids, but with Guillain-Barré, not so much. IV immunoglobulin is the big one that we're going to try to get patients to do. But you want to monitor for blood clots and renal change. I don't remember if I said diagnostics. Oh yeah, so MRI, rule out MS. The other thing that's diagnostic about this is you're going to have elevated protein in your cerebral spinal fluid from like about a week to 2 weeks after you start having symptoms. And then also your nerve conduction exams are going to be abnormal. So really your priorities with Guillain-Barré, like I said, making sure you educate your patients that like just because they don't have function now doesn't mean that they're not going to have function forever. It will come back proximally to distally, even though it's a distal to proximal disease. You're worried about airway because of those respiratory muscles. You're worried about their INO. And they also might start to feel powerless because, I mean, if your body is essentially just like you're losing function, like obviously you're going to feel powerless. Okay, so that is all I have on like all the nerve disorders. So MS, trigeminal neuralgia, Bell's palsy, and Guillain-Barré. As I asked you guys about, I heard that you didn't have a PowerPoint with this information. Being honest, I don't even remember if we did. But hopefully that's just like the gist of what you guys talked about in class and what you need to know. The last thing that I have for chronic neuro is Parkinson's disease. So Parkinson's, I feel like we've talked about just like a lot in nursing school, especially with pharmacology. So hopefully some of this is familiar. So Parkinson's is more common in men, and it's a progressive and chronic degeneration of an unknown cause, and it's a lack of dopamine in the brain. So remember that, lack of dopamine. You're also going to have these Lewy bodies, or LEWY. I'm assuming that's pronounced Lewy. Lewy bodies, which are clumps of protein found in the brain that can also cause dementia. The characterization of Parkinson's, so there's a triad, because of course there's a triad for everything. So we have tremors, which is usually the first sign that someone is developing Parkinson's, and that's like the pill rolling with your thumb and your forefinger. So that's the first part. Rigidity, which is like the cogwheel rigidity, where you like, that's kind of like when the gait disturbance, and that's also seen with the flat face. And then bradykinesia is your final sign, which also pertains to the gait, which is like the short shuffled gait, your slurred speech, and postural inability. Other symptoms, they're more prone to like emotional outbursts, depression, anxiety, fatigue, incontinence, short-term memory loss, drooling, that sort of thing. But remember the triad of tremors, rigidity, and bradykinesia. Basically, with Parkinson's, everything slows down. So, they might be constipated, for instance. So you want to increase fiber, fluids. They might move slowly, so they're at an increased risk for falls. So remember that, and remember your fall safety. Diagnostics, they're going to be an MRI to rule out other things, and then also they're going to have a positive response to the drugs that we're going to give for Parkinson's. Obviously, if they don't have Parkinson's, then they will not respond to the drugs that we give. As far as nursing interventions and treatments, so there are a couple types of surgeries you can do. I don't really remember anything about that. Nutrition, they are gonna need like adequate nutrition, like I said, because they're more than likely to have constipation. And then also just because like these patients are losing independence, and so you want to make sure that they maintain nutrition so that they don't get like even worse, and so that they're not at risk for other things. Shakes are really good. Vitamins are really good to like maintain calories, since they're not gonna like eat as much. And also you want to do like small pieces of food whenever you feed them, because they're at an increased risk for aspiration, because like I said, like everything slows down, and so they're not able to swallow as well. You also can have movement training, which I feel like this was a question that we had on the exam. So one thing that you can do, I think this was select all that apply, and it was like different types of interventions. But one thing you can do is this movement training, which is where you sit at the side of the bed, or have your patients sit on the side of the bed. You rock them back and forth before getting them up, and then once they're up, they walk along like an imaginary line. So it's supposed to help with stability. And then, like I said, when they walk, it's like cogwheel almost, and they're shuffling. So it's supposed to help them kind of just have something that they can follow, so that they're not as like likely to fall, if that makes sense. You might have to also address communication, because they might not be able to talk to you as well. The big drug with this is levodopa carbidopa. You definitely need to know this drug. Remember that it can take weeks to months to take effect. You should report any uncontrollable movements to your doctor. And I have this highlighted. So you want to have a moderate, consistent protein intake, because if you have excessive protein intake while you're taking this drug, it can like counteract and just not do what it's supposed to do. It's also given in multiple doses. And basically this just works with the dopamine. So levodopa carbidopa, remember that, can take weeks, and remember the protein. And then your second line of defense is your dopamine receptor agonist. So with these, you want to monitor for orthostatic hypotension, severe headache, and confusion. But that's all I have on those. So, really, with Parkinson's, your main issues are mobility, nutrition, swallowing, communication, and safety. Safety, 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 because they are an aspiration risk, and they're at an increased risk for falls because of that unsteady gait. And so, this is one of those instances where you might have to get involved with an SLP to do like a swallow study. If they have Parkinson's, they might have to have their liquids thickened. You probably are going to have to feed them. Parkinson's patients also can have a lot of like neuro side effects like as it gets worse. So I got floated one time to the neuro unit at Barnes, and I had a patient she had Parkinson's, and she was like severe, like very, very, very end stage Parkinson's. And she just was like, I mean, it's kind of eerie almost the first time that you see an actual Parkinson's patient, because that like mask effect, like it is 100% true. Like it's one of the strangest things, like walking into the room and she's just staring at the wall, just blank expression, but like they will try to get up out of bed. This girl, she had hallucinations, so like the worse it gets, the more side effects you're going to have, the more clinical manifestations you're going to have. So I would remember that. Okay, and then I don't remember. Dr. Schneider sent me a list of all of the topics that you guys are being tested on, and I can't remember. He took some stuff off, so I just want to make sure. So, restless leg is not on there. Okay, but myasthenia gravis is on here. Okay, so we have myasthenia gravis and then ALS. I'm going to do ALS first because I don't have that much on it. ALS. Just had ALS Awareness Day, I think like 2 days ago. So, ALS is a rare, progressive, degenerative neurodisorder with loss of motor functions in the brainstem and the spinal cord. And I'm sure you guys are all familiar with ALS and how deadly it is, but basically, after a patient is diagnosed with ALS, their death is probably within 2 to 6 years. It's a very quick, very just like it takes over your body and you just lose function entirely. And so it will eventually impact everything in your body and like every system. The thing about ALS though that I remember this like the big point about is ALS patients, they remain intact cognitively. So like they can understand what's going on, which is why this is so brutal. Like they can understand what's going on. They know what's happening, yet they might not be able to pick up their fork. They can't talk to you. They drool. They can't walk. So it's just really, really important that with ALS patients, you include them in the plan of care because they can understand you. You promote independence. Like if they are able to hold a spoon and feed themselves, even if it takes extra long, like, okay, like you want to make sure that they can do that, promote that independence. Diversional activities can also be used. Passive range of motion, you're worried about pressure ulcers, all those things from mobility or immobility that we've talked about time and time again. Support them emotionally, cognitively. And there's really no diagnostic test other than looking at symptoms with this. So, very sad, very quick, just thing to remember. I don't have anything other than just like being aware of the causes or the side effects that immobility can have, and then also supporting them cognitively. Myasthenia gravis. Okay, this is the last thing I have for chronic neuro, and then we will be going into shock, mods, and SIRS. So, how long are we at? Dang, 50 minutes. Okay. Okay, so myasthenia gravis, I used to get this confused with Guillain-Barré. To be honest, I still kind of do. Myasthenia gravis is not as common, but it's another one of those autoimmune diseases of your nervous system. So it causes weakness in the upper part of your body and certain skeletal groups like your head, neck, and chest. But basically, what happens is your immune system attacks acetylcholine receptors, and so they can attach and have muscle contractions. And so, like, if you can't contract your muscles, like, you're just going to be weak. It can be exacerbated by pregnancy, emotional distress, menses, illness, trauma, temperature extremes, hypokalemia, things like that. So, your clinical manifestations, so just like I said, overall weakness in skeletal muscle that fluctuates from the involved muscles, and just like you're gonna have weakness throughout the day. So, usually your eyes and your eyelids are involved. So, you might have like a droopy eyelid, chewing and swallowing trouble is really big, and then speaking and breathing problems are really big. You're not going to have any like sensory or reflex changes, and the trunk and your extremities aren't really impacted. So that's why I said it's like pretty much from your like chest up. Diagnostics. So you're going to look at like their vitals, you're going to look at ABGs, pulmonary function testing, because like I said, you're going to have a lot of respiratory symptoms. So you're worried about ruling out things like that. Chest x-ray. There's a test called the tinselin test, which is when you inject tinselin into the body, and if you have improvement of your symptoms, then that's a positive sign. You can also have the eyelid fatigue test. So that's when they gaze up for 2 to 3 minutes and they're not able to do that because, like I said, they have like the droopy eyelid. Medications. So you can use cholinesterase drugs. So that enhances those neuromuscular junctions, breaks down acetylcholine, and facilitates the impulses so that you can contract your muscles. Mistonin is the most common. You can also have immunosuppressants, steroids to suppress the immune system, that sort of thing. The biggest thing with myasthenia gravis is you want to monitor respiratory status and airway clearance, because you're worried about airway since it's from the chest up. And one important thing with this is a myasthenic crisis, which is when your swallowing and your breathing reflex are affected. So you have a high risk for aspiration and respiratory insufficiency. So if you have myasthenia gravis, you can go a while without having symptoms, and then you have like emotional stress or pregnancy, and then it flares up, and that's the crisis that you have. So that's like the sudden weakness in your eyes, eyelids, chewing, swallowing, high risk for aspiration and respiratory status. So airway, respiratory status, that is what you're worried about. They obviously shouldn't be PO if they fail a swallow test. You're worried about, are they able to breathe? So look at their O2 stats, things like that. Okay, so that is everything that I have on chronic neuro and all of like the nervous system stuff. Like I said, it's a lot. Like that literally took me almost an hour. If I'm being honest, I would say, I would have a good understanding of each of these, but like it's not like stroke, ICP, and shock where you're going to have like a good amount of questions. Maybe have 2 or 3 questions from each of these topics. So I would just look over like the big things that, anything that I mentioned that he also mentioned is probably going to be on the exam. But yeah, I tried to go fast because I knew this was going to be long. So if you were confused by anything, send me a message or something and I can easily go over it with you. But I feel like if you guys understand that, you will be just fine. Okay, so let me get my stuff set up here and we will go over shock, SIRS, and MODS. Okay, so last little bit of your exam 1 is shock, SIRS, and MODS. I would say that shock is a pretty good portion of your exam, or like pretty big topic for it. Really, shock isn't like a super difficult concept to understand, but there's just a lot of really like crucial things like nursing intervention wise that are important to understand with shock that we'll go over here. So shock. So shock is overall decreased tissue perfusion that leads to impaired cellular metabolism. So biggest thing, when you hear shock, you should automatically think hypoperfusion. That will be a question somewhere, I can guarantee you. Hypoperfusion. What's happening is your body is not getting out what it needs to get out to the tissues. So your tissues are just like, what the heck's going on? You're going to have a decrease of oxygen, glucose, and nutrients reaching your tissues. And so that's obviously going to impact like lots of areas of your body. So vasodilation, hypoperfusion, lack of tissue perfusion. Okay, that's like the same thing as hypoperfusion. Vasodilation, hypoperfusion. Two biggest things that you need to remember with shock. And then the rest of this is essentially just like the kinds of shock. So 4 kinds of shock. So cardiogenic shock. This is when you have reduced cardiac output. It's usually caused by like cardiomyopathy, dysrhythmia, hypertension, that sort of thing. But basically the problem is that the heart cannot pump blood forward to perfuse the organs, or it can't like fill properly with enough blood to perfuse. And so older adults are usually more at risk for this, but bottom line is there's going to be decreased cardiac contraction, and so there's decreased cardiac output. And so that is where you see these symptoms of tachycardia, because your heart is beating faster to try to get blood out, and you're going to be hypotensive because you don't have as much blood volume. And so your heart is going to be beating fast and you're going to have a low blood pressure. But bottom line is with cardiogenic, it's the failure of the heart to pump right. And so you're going to look at medications that are going to increase contractions and blood flow. So you're going to look at nitrates, you're going to look at your, oh my gosh, like epinephrine, intropes, so like dopamine or dobutamine, things like that. Your diagnostics and education are just going to be about like looking to see if they have an MI, do they have something structurally wrong with their heart. So just like do an EKG, maybe go to a cardiac cath lab for, do they have a blockage, things like that. So cardiogenic, something's wrong with the heart, so it can't pump right. So you're going to have tachycardia, hypotension. Hypovolemic shock. So this is when you can have absolute hypovolemia, which is like external loss of whole blood or bodily fluids. So that would be like if you're vomiting or have diarrhea, if you have a hemorrhage, that sort of thing. So like think outside of the body. Whereas relative hypovolemia is related to blood that's just like shifting and pooling as a result of this vasodilation. So the biggest one with this is burns. So like you're not actually losing volume with burns, but it's all shifting around. So that's going to cause the signs and symptoms that you see with shock. Very important. I remember we had a question like differentiating between absolute and relative. So absolute, think about relating to surgery, a GI bleed. So you're losing blood through the stool, diabetes insipidus, vomiting, diarrhea, hemorrhage, bleeding, sweating, anything like that. Third spacing, burns, that's going to be your relative, along with maybe like ascites of your long bones or a ruptured spleen, hemothorax, things like that. Bottom line is, though, with a hypovolemic shock, whether it's relative or absolute, is you're going to have a decrease in volume. So that means you have a decrease in venous return to the heart, and therefore a decrease in cardiac preload to the heart. So basically, your heart isn't getting the fluid that it needs, and so then it obviously can't pump out the fluid that your tissues need. And so that's why a huge part of this is knowing your signs of dehydration. So, like increased thirst, urination, paleness, because that could lead to shock. You want to give fluids and blood back to patients first. That's your first priority with that. Very important. First priority with this type of shock is to replace the fluids in the blood that was lost, and then move on to your blood pressure control with like vasopressors. If you had a hemorrhage, you're going to be looking at labs because their hemoglobin and hematocrit are going to be low. So know those numbers. And just think about volume when you think of hypovolemic. The another type of shock, third type is obstructive shock. So there's always confusion about the difference between obstructive and between cardiogenic. So as I talked about, cardiogenic is something where the heart can either not pump blood forward, or it can't like fill enough to get the blood that it needs to perfuse. Whereas obstructive shock is an impairment of the heart to pump. So it's a non-cardiac related reason. So think about like a PE, a pneumothorax, cardiac tamponade, because cardiac tamponade, it's not the heart itself, it's the fluid around the heart that's causing it. So I hope that makes sense, but like think about cardiogenic is something with the heart, whereas obstructive is something not with the heart, but it's affecting the heart's ability to pump, if that makes sense. So you're going to want to treat that. So like if they have a pneumothorax, you're going to want to put a chest tube in, embolectomy if they have a PE, if they have a cardiac tamponade, pericardiocentesis, that sort of thing. And then finally, you have distributive shock. So there's 3 kinds of distributive shocks. You have neurogenic. I believe we already talked about neurogenic with spinal cord injury, but usually this is a high thoracic injury caused by a high thoracic injury, T6 and above, loss of sympathetic tone that leads to vasodilation. And so that's going to cause bradycardia is like your biggest symptom with neurogenic shock. So, and this is the only type of shock that has this. So just remember that. Only type of shock that has bradycardia is neurogenic. But like you're also going to have hypotension. And so you want to treat the hypotension once again with your vasopressors, atropine for the bradycardia. And you also want to treat the spinal cord injury. Anaphylactic shock is also distributive. So remember, this is like the hypersensitivity to a substance, allergic reaction, antigen antibody reaction. So this can cause respiratory distress, angioedema, bronchospasm. So you're looking for like flushing, dizziness, itching, stridor, things like that. You're just looking for those signs and symptoms that indicate an allergic reaction, and the biggest treatment for this is epinephrine. You can also use an antihistamine, so just remember those can cause drowsiness. You can use like Zantac, steroids, bronchodilators. Airway is the biggest thing with anaphylactic shock, and they should wear a medical ID bracelet to avoid allergens. And then septic shock is the last type of distributive shock. So this is an exaggerated response to an infection, and it has a high mortality rate. So you're going to have decreased tissue oxygenation essentially as a result of something rotten. So biggest thing with sepsis is you can have a high lactate level, tachycardia, hypotension, fever, tachypnea, and then warm skin because the skin is the largest organ in the body, so like it's obviously impacted by the perfusion issues. By definition, with sepsis, with septic shock, you can bolus them all day long. You can give them all the fluids they want and they're not going to respond. They're not going to be able to keep their pressure up. So I have this prioritization question. I know this was a question. We had to like put things in order. So if you have a patient and they have septic, you're suspecting them of having septic shock, you're going to give them a bolus because you don't know if the bolus is going to work or not, obviously, until you give it. You're going to put them on like monitoring to monitor their vitals. Then you're going to do a blood culture to see what the infectious agent is. And then you're going to give antibiotics only after you've done the culture. So septic shock, just like you have an infection somewhere that's just causing decreased tissue oxygenation, basically like your vessels. I remember he explained it to us like your vessels are essentially like septic pipes and they get clogged with infectious material, so they can't get out what they need to get out. And so you're going to have your white blood cells are going to activate. You're going to try to get rid of this infection, things like that. And so the progression with septic shock is it goes from sepsis to septic shock to profound circulatory and metabolic abnormalities to hypotension that just like doesn't respond to anything. So as for the shock stages, so that's like all the kinds of shock. So shock stages, I have compensatory, progressive, and irreversible. So compensatory, that's when your body's trying to like figure out what's going on and it's trying to adapt. So that's when you're going to see the decrease in your blood pressure, increase in heart rate and respiration rate. If you guys remember the Cushing's triad from ICP, shock triad is the complete opposite. So with your shock triad, you're going to have decreased blood pressure, increased heart rate, and increased respiration rate. Whereas with Cushing's triad, with ICP, you have increased blood pressure and then decreased heart rate and decreased respiration rate. The only time that doesn't apply with shock is with neurogenic shock because you have bradycardia. And then the progressive stage is when everything just continues to get worse. So your blood pressure is going to keep dropping. You're going to have anasarca, which is just like generalized edema, crackles from like fluid in your lungs, and it's basically like the precursor to MODS. And then irreversible stage is when you just have like terrible hypotension, hypoxemia. Your organs are just going to be accumulating waste and you really can't recover from this stage because your body is just too overwhelmed. So SIRS is systemic inflammatory response syndrome, and this is when you have too many particles, what? That's tissue. Okay, I literally have 2 bullet points on SIRS and they don't make any sense at all. So SIRS is basically just widespread endothelial injury and dysfunction. So like tissues are just going to keep dying, and so edema and neutrophils just continue to become trapped. And so that gradually leads to MODS, which is multiple organ dysfunction syndrome. And so MODS is when you have 2+ symptoms that are impacted, and you went through shock, you went through sepsis, you went through SIRS, and now you're at MODS. And so the biggest thing with MODS is you need to know like how to evaluate each type of system. So like with cardiovascular, you know, you're looking at myoglobin, you're looking at troponin, and remember your troponin is most specific to MI. You're looking at your creatinine kinase. With lungs, you're looking at, you know, your pulmonary function test. GI, livers, look at your liver enzymes, your AST and ALT. Renal, you're looking at creatinine. So remember your normal creatinine is 0.8 to 1.2. You're also looking at BUN, so no BUN is 7 to 20, that's normal. And then skin dysfunction also because your skin is an organ. So you're looking at like albumin, which should be less than 5.4. So yeah, you're literally just like assessing each system, and there's not really like a specific diagnosis that can tell us what's going on. So, signs and symptoms, look at LOC changes like restlessness, confusion, impending doom, weakness. Like I said, they're going to have tachycardia, hypotension, and tachypnea, cool, clammy skin, decreased oxygenation. Yeah. So, monitoring, obviously, you need to monitor their vitals and do neuro checks, monitor their output, emergency management, and collaborative care for shock, SIRS, and MODS. So, you're going to monitor the ABCs, airway, breathing, circulation, stabilize C-spine, apply your O2, and intubate if you're needed. IV access, they should always have 2 large bore IVs, control bleeding, and you're going to treat the hypotension. That's the number one thing you're going to do, is give those vasopressors and give fluids. They're probably going to have a catheter and an NG tube. Blood cultures after you determine there's a possible infection. 12-lead EKG. So things you're going to do as well are fluid resuscitation if it's hypovolemia. We already talked about that. So replace the fluid, give pack red blood cells, have those 2 large bore IVs, normal saline. Your vasopressors are for your hypotension, so like norepinephrine, dopamine. Vasodilator drugs are for if the MAP is greater than 65. So yeah, I remember we had a prioritization question with shock. I don't remember if it was like what I said with the shock with sepsis, or if it was like shock as a whole. I just know that you give the bolus first. Give the bolus first, because that determines what happens after that. So, okay, that is all I have for shock, SIRS, and MODS. I feel like that was kind of all over the place, but just know your shock is because of hypoperfusion. So you have hypotension, tachycardia, and increased respiration rate. Know your types of shock, so cardiogenic. Know how to treat them. So cardiogenic, you're gonna give the nitrates, things like that. You're looking at cardiac related symptoms. Hypovolemic, know the difference between absolute and relative. Know how to treat that. Distributive, so you have neurogenic, anaphylactic, and septic. No, neurogenic is the only type of shock that you see bradycardia with. Airway is what you're worried about with anaphylactic shock. And then septic, remember, you don't do blood cultures you do blood cultures and then you do antibiotics. And then obstructive shock, remember, is your heart is having issues pumping, but it's a result of a non-cardiac reason. Your stages, SIRS, I literally don't remember anything on SIRS, so tells you something. And then MODS is when 2+ symptoms are impacted, so know how you would evaluate each system. Assessment, you're looking at pretty much everything. Know, your prioritization, so give a bolus. You don't give, or you don't do a blood culture until, you don't give antibiotics until after the blood culture. Your vasopressors are going to treat your hypotension, so know your different vasopressors. And yeah, I would really, 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 really recommend using registered nurse RN. I think I talked about this, but using her for any topic that you can with Schneider's exams, because she does a really good job of just condensing information, and she also gives practice questions. I used her for literally every topic that I could. So I know she has some stuff on seizures. I'm pretty sure she has stuff on Parkinson's. I know she has stuff for a fact on shock. So I would 100% use that. Like, there's no reason why you can't. And it'll definitely help you. So, like I said, I will either post a really short video like tomorrow or like a document just kind of going over, just like listing the topics that you should know for each week. Obviously you guys don't have to watch every single one of these videos. You can pick and choose. If you're struggling with stroke, you can go watch my stroke videos. That's kind of the point of why I'm doing a video every week, is so that you guys can get in-depth reviews about every week in all your content, rather than just like some of your content right before the exam, if that makes sense. Like, I don't want it to be a cram sesh. But as always, if you have any questions, feel free to let me know. And if not, have a great weekend, and I will talk to you guys soon.